Morning, everyone. Thank you. I would like to thank all the delegates who had come here despite being the last session on the last day. Thank you for that. We'll go ahead with the talk. We need to know how to get freedom from glasses after cataract surgery. All of us know now cataract surgery is more of a refractive surgery. And how do we achieve, if not all, at least most of our cases? And in that, the first topic would be target emmetropia, how to choose the right machine, right method, right formula. Let's remember, this is the most important thing that we need to do, whether we are using monofocal, multifocal, EDOF or advanced monofocal IOLs. And Dr. Shahbaz Mohammed will tell us how he does that.
So good afternoon, everyone. Really, we have to thank for whatever audience is there. So last session, everybody wants to go back home. So, and thanks to Elan for including me in his course. So we will be coming with directly to the topic. See, this, the history, like Sir Horrard Lidley implanted first IOL, and the refractive surprise was -20. And he has a series of 5 cases, -20, -21, -18. So given technology advancement in cataract surgery and introduction of premium intraocular lens implants, patient expectations continue to rise, and refractive error following cataract surgery is no longer tolerated. Now, even if -1 or 0.75 come, patient will immediately complain. So emmetropia with plus minus 0.5 and 1 cylinder, less than 1 cylinder, is a goal in cataract surgery, but was reached in only 55% of cases. A lot of studies has assured that. The factor precluding emmetropia include remaining corneal astigmatism, which is not under our control, and biometric prediction. So we will be concentrating on this thing. So ocular biometry refers to measurement of anatomical dimension of the eye. So component of IOL power calculation are axial length, corneal power, effective lens position. Now axial length and corneal power can be correctly calculated, but effective lens position can only be predicted. It cannot be calculated. Then putting them in a formula. So biometry has become one of the most important steps in modern cataract surgery. As Dr. Elan was telling, if biometry is not correct, whatever lens you use, whatever good surgery you do, results will not be good. So axial length, like effective lens position, is defined as the distance from the anterior surface of the cornea to the effective principal plane of IOL in the visual axis. Now again, as I told you, the effective lens position prediction can be done with lot of parameters, but exactly we cannot calculate. And Y is defined as the distance from the principal plane of IOL to the photoreceptor of the macula axis. And combining these two gives your axial length. Now why it is very important? 1 diopter of change will cause 2.5 diopter refractive error. And in longer eye, it goes down to 1.75. In shorter eye, it increased to 3.75. So shorter eyes are more important to be more careful in checking the axial length in that. So now we have ultrasound, we have optical. Now after optical has come, it has become a gold standard, but still lot of cases you still require ultrasound. So transducer is used to send ultrasound pulse more than 2 kilohertz, roughly between 8 to 10 megahertz, to create a sound beam which passes through the eye. Sound beam is reflected back at interface of changing tissue density. These echoes are displayed as a vertical spikes rising from the baseline. The time taken for sound wave to return back is converted into distance using the velocity of sound through various tissue. Now these are the various tissue, and these are the machines. There are many in the market, but anyone you can choose. Most of them are good now. Now application we will skip, but I just wanted to show like how to do. We all have assistants, we don't do that. We should know how to make the position of the patient comfortable and ask them to look straight. Adjust the tip and support it with your hand. The finger supporting is very important. It will reduce the pressure on the cornea. And then the machine will take automatically the readings once it's arrived, and then it's average and give you. If the readings are very high, I think it is very high, then you have to remove that and average from the norm. Now this is, so coming to the immersion. Patient is placed supine in the reclining chair, local anesthetic is filled, scleral shell is applied, and then the fluid you have to use. Avoid air bubbles because that will change the speed of the sound. And this is different types of shell. And now coming to the video. Again, make the head position proper and ask the patient to look at the ceiling or give a proprioceptive stimulus to them and then apply the shell to the eye. Fill it with the fluid. And slight adjustment you have to do. Once it is adjusted, again the machine will start taking the reading. And it will take from 10 to 15 readings. You have to examine these readings. Wait, it is jumping.
Actually, the slides are jumping. Will someone? Slides are jumping.
Don't use the, just use the space.
I thought like time is.
Use the space bar. Use the space bar for next.
Yeah, that's what I'm doing.
Instead of the arrows, you can use space bar.
Okay. The ultrasound probe is inserted in the shell such that it is around 5 to 8 millimeter away from the cornea. Ask the patient to look with the fellow eye at the fixation point at the ceiling. In one eye patient, you can use proprioceptive stimulus, and gentle movement of probe will align the probe and it will start giving the reading. So this is what the, no, it is automatically jumping. So when you have to do remeasurements of the these eye, when you will get like the difference of the two eyes is more than 0.3 millimeter, very high axial length, very low axial length, try to repeat your reading, and axial length doesn't correlate with your refractive error, then also you should repeat your limit. So in ultrasound, keratometry cannot be done, so we do keratometry separately, and keratometry can be done with a manual or automated. Most of us have shifted to automated. These are the old manual one. We have to align the mares, and then we have to take the reading. I think there's some problem is there. It is. Okay, we'll just take the button. So this is like coming to the optical one. And optical, you don't require the patient to fix with the other eye. You have to just align, make the patient's head straight, align your machine with that, and ask the patient to look to the stimulus. And the machine, once it is focused, it will start taking the reading. And in this, any reading which is abnormal, it will be marking. Finish.
Optical and formulas.
So I think. So this is what the reading comes, and you can see that mark is there. So that means that reading is abnormal in that, and that you can manually remove and edit. So what optical tonometer takes? Axial length, corneal thickness, aqueous depth, lens thickness, flat and steep meridians, and astigmatism, and white to white, and the newer has some other parameters also.
What's the problem
So,
with this laptop? Okay, go back to the
no, it's okay.
formulas.
Formulas come later. So advantage, so more accurate measurement. Macula, measuring optical axial length, unlike ultrasound biometry, which measures the other length. Measure axial length from corneal epithelium to Bruch's membrane.
Timer set.
Ultrasound biometry measures only till ILM and adding 200 microns of retinal thickness. However, retinal thickness varies from 160 to 400 micron. Hence, in optical biometer, no additional assumption of retinal thickness is needed to be made. While in ultrasound, you made assumption like 200 we have made on average. Use partially coherent light, and it's a non-contact. So application, opticals are much better than that, but the disadvantage, it is costly, everybody cannot have that. Dense cataract, corneal opacities, posterior polar cataract, posterior subcapsular cataract, white cataract, all these cataract, you still go back to your ultrasound, and immersion is equally good as we are told, and you can utilize that. So modern third and fourth generation IOL formula, prediction formula, which use up to 7 pre-operative variables, have improved the predictability of refractive outcome and transform routine cataract surgery from a procedure intended to simply restore sight to a refractive procedure. So now we say patient, even you have high power, you can do cataract surgery and you get rid of glasses rather than doing. So for normal axial length from 22.5 to 24.5, most formula works very well with minimal discrepancies. Hofer-Q formula provides the most reliable results in shorter eye, while SRKT was best in long eye. For high myopia, even Barrett's 2 formula may be a suitable choice. Some studies have demonstrated the high level of accuracy with Hingis formula in extreme hyperopia. Fourth generation formula like Barrett's, Hingis, and Holiday 2 formula have the advantage of including the non-proportionate relationship between the IC depth and axial length, and therefore should provide the high accuracy over the full range of axial length. So this is the chart. I think most of us have seen this. So last you see the Oslen and Barrett 2, it's good for all cases, and Barrett 2s are not available in basic machines like optical biometers. So what I used to do is I will just take the reading, send it to the company and ask them to calculate with the Barrett formula, and we use that. So I think we can conclude with that.
Yeah, thank you for an excellent talk. 1 minute, Dr. Shabas, please wait. There's a slight change in the program. Dr. Subhash Prasad sir has a presentation in another hall. I request him to get the slides ready. Meanwhile, Barrett for a person who doesn't have is also freely available online.
Yeah, that is one thing. Either you can calculate yourself online, otherwise all companies having Barrett formula, you just ask them to calculate and give the IOL. Now the responsibility is on company whether they have given correct lens or not.
Any questions to Dr. Shabas? Thank you, Doctor. Dr. Shabas is from Coimbatore with Trinity Eye Foundation.
Trinity Eye Hospital.
Sorry. Dr. Subhash Prasad, I always tell he was the senior resident to my senior residents, an exceptionally good speaker, and he's from Patna. Sir, please go ahead with your talk.
Thank you,
on premium monofocals.
Thank you, Dr. Alan, for accommodating me in this series, in this COPOs. So I would be talking on premium monofocals, technology advantages and disadvantages. We all know that phaco with the foldable eye is the procedure of choice for any cataract surgery nowadays. And with advancements in technology, there has been a lot of changes in the intraocular lenses also in last few decades. But the profile of the patient keeps changing, and this is putting a lot of pressure on not only on industries but on ophthalmologists to perform and to give a better and better result. And there has been a rapid shift to digital platforms for last few years that has created actually a rapid increase in far through near vision demands. So as a clinician, our goal is to have a happy patient at the end. So this is also moving very fast.
Thank you.
So what is ideal IOL should have been? It should be able to give vision for all ranges, should be able to give good quality of vision in low or bright light conditions, and there should not be any negligible night vision problem or no problem. So traditionally also before the advent of the trifocal or EDOF lenses, we used to use some kind of offset in the IOL power calculation, which is called monovision, to just make some of the patients who actually wanted some near vision to make them happy. But the revolution was with the introduction of the bifocal lenses or trifocal lenses or EDOF lenses. But these lenses are not without compromises, particularly the night vision problems, and the cost is a very limiting factor. So if you are really worried about the compromises like the night vision problems or low contrast, or if you want just some better functional vision at more distances, then premium monofocals, which is a new concept, can be a very good options. can be a very good option. And these are basically monofocals without any concentric rings, or so they don't split the light energy into different places. Rather, this technology uses a different kind of like slight change in the central power, or utilizes the spherical aberration of the lens to give superb distant vision, not only superb distant vision but also intermediate vision and some amount of near vision also. And if you implant these lenses bilaterally, then these lenses perform even better than the simple monofocal lenses, and patient can utilize a lot of intermediate work with these lenses. And if you do some adjustment in the other eye, like you do monofocal kind of adjustment with slight offset to the power, the patients can have even still better. So these are the three lenses which are available in the market nowadays. Technics enhanced intraocular lenses which came first, then came the Rayner and Vibinex from the Hoya was launched few months back. And with these lenses, some of the patient really can have some improvement in the intermediate vision. So what is Technics enhanced lenses? This is basically using the same platform of Technics 1 single piece lenses, and you cannot make out any difference. How does it work? There is small continuous increase in power in the central 1 millimeter diameter zone of the aspheric anterior surface, which actually gives around 0.5 diopter of change in the power, and which enables us to have an enhanced intermediate vision with better image contrast as opposed to the trifocal or EDOF lenses, and it is flexible also. The monocular defocus curve shows a better defocus results between 1 to 1.5 diopter, and even the binocular defocus performs better, and it achieves a smoother profile along the entire curve, especially within the intermediate defocus range. It provides higher independence to the spectacle as far as intermediate vision is concerned if we implant the lenses bilaterally. And the night vision problem or the contrast is even same as the monofocal lenses. The another lens which is available in the market is the Vibinex Impress, which is on the platform of Vibinex. It comes as a preloaded. The other one is not preloaded yet now, but it's going to be launched as a preloaded version. The toric form is in the preloaded form. This lens is available in the preloaded form. Here there is slight alteration in the central 2 millimeter, which actually enhances the intermediate vision by one line. Here also you can see the defocus curve. It enables us to have a better intermediate vision by 0.5 diopter. The lens which I find much more useful than these two lenses, I have no financial interest to any of these lenses. Recently I started using this Ray-1 EMB, which is hydrophilic lenses. It was developed in collaboration with Professor Graham Barrett. It is actually, the name suggests, Rayner EMB means enhanced monovision lenses. It can deliver up to 1.5 diopter of high quality vision. It utilizes a unique positive spherical aberration designed to extend the intermediate vision and some amount of the near. At the same time, since it is a non-defective IOL, so it's just like monofocal IOLs, so there is no night vision problem, and it comes in beautiful preloaded pack. How does the EMB lenses work? The anterior surface of the aspheric, the lens is aspheric, but the central region induces controlled positive spherical aberration of say around 0.15 micron, which extended the depth of vision, and this zone is blended with the aspheric zone, so there is minimal loss of visual acuity or contrast sensitivity, and being non-reflective, it doesn't have any night vision problem. So this, you can see that how the spherical aberration can shift the focus for quite some distance. This is the defocus curve of the Rayner EMB lens as opposed to any monofocal lens. If you offset it by little bit, say around 0.5 diopter, you can manage the patient to have to give nearly 1.75 diopter of extra benefit in these lenses. And if you give 1 diopter of monofocal of monovision in the other eye, the patient can have very good near vision also. This is the chart just to show that if you adjust the lens, you offset the lens by 0.5 diopter, you can cover to some extent even the near vision also in these patients. But all these lenses are not only without advantages. there are some limitations. Advantages being that with so low cost, you can give some amount of intermediate vision and even some amount of near vision without any night vision problem. But there are, these lenses do have limitations, and it is said that in optics there is no free lunch, because the photons of light which is going inside the light is constant. So if you are adding somewhere here, you are actually decreasing some amount of distance vision also. So that is one flip side of these lenses, that you can, but practically it doesn't affect much, since the already patient of cataract, they have low vision. So once they get this amount of good vision, they are very happy. And the other limitation is that just 0.5 diopter of increased depth of focus is with the other two hydrophobic lenses, but with the Rayner it is even more than that. So you can have additional 1 or 2 line of intermediate vision, that is around 60 centimeters of the distance you can have one that. One has to remember that this is not an extended depth of focus lenses like Symphony or VVT, so the patient will not have that much of good vision. Our experience, we have implanted nearly 25 eye hands, EMV is 51, and what I feel that the EMV lenses are doing much better than the other two lenses, and the patient's happiness is much more with that. Only disadvantage that this is hydrophilic lens, but in last 9 months I have not come across to any PCO also. So patient satisfaction is best with the this is just a small video clip just to show that this lens is so good to implant. This is toric, it comes in toric form also, just 30 seconds. Alan. So this goes with the 2.2 millimeter without any wound stretching, and this stays in the place in the toric also, it gives very good results. So just to summarize, it's exciting new concept to address the new intermediate vision and some amount of near vision with the monovision concept. And this is cheaper version, you can say this is cheaper version of the EDOF IOLs, giving good quality of vision without any night vision problem. So thank you very much.
Thank you. Sir, can it be called as a true EDOF IOLs?
Actually, FDA doesn't approve these lenses as EDOF. Yeah. There are certain criteria which has to be fulfilled. So this.
But they provide the benefits of like that of an EDOF.
Yeah.
That is what you.
Yeah, yeah.
That is what we have also experienced, but we wanted to know.
Just my personal experience, I want to share that I have implanted so many VVD IOLs, and when I compare these two, at the cost of 1/3 or less than that, the patient much more happier with this Rayner lens. Yes.
No, I think now even the eye hands now they are commercializing as advanced monofocal plus. They are not pushing as EDOF, so
Yeah,
they
yeah.
also know.
Technically, I want to
So do we do?
Dr. Nilesh, sir.
So do we counsel our patients for these IOLs or EDOF ones? Because this is a very important. I mean, when you are going to a premium set of IOLs,
No,
true EDOFs are little too costly, and these smarter EDOFs are less costly. But what do you explain to the patients?
see, with the EDOF, I explained that you will have a very good intermediate vision, but you will require some amount of the near vision. But here you won't have any near vision, particularly those IHANs and other.
But with no financial interest,
Yeah.
Is there any difference between that Vivity EDOF and this iHands Smart EDOF?
No, these are not EDOF actually. The IHANs is not EDOF. VVT is designed to give much better intermediate vision, and it gives some amount of near vision also. I have seen patients who require just 0.75 diopter of additions, 0.5 even bilaterally. Some of the patients did not require any near correction. So
you mean to say that we should keep these patients in, I would say, extended monovision. That is all.
Yeah.
I mean, switch over to that, not EDOFs.
just slide one line of improvement with the near vision, nothing more than that. But Rayner performs better.
Sir, in
Just clarify on this, what you asked. Technically speaking, sorry. Yeah, technically speaking, all these are extended depth of focus lenses. All these lenses, whatever sir was trying to explain, central increase in power, it's not just the power, it's the asphericity that has changed. We are playing around on that. I'll have a slide on that. I'll be talking about it. Number two, but FDA considers EDOF as above 1.5 diopters. If it can give 1.5 diopters at least of addition, only then FDA considers it. So what you named as true EDOF, there's nothing called true and false EDOFs, nothing called like that. But these are also EDOF lenses giving less than 1.5. That's what sir was telling, intermediate is good, near is not good. There is a method to play around for that. That is the blended vision correction, where 1.25 to 1.25 is given by Rayner EMV lenses, 1.25 to 1.5, it goes till there. So in the other eye, that is in the non-dominant eye, give a slight overcorrection of 0.75 to 1.
Yeah.
I have nearly 200 patients with this, and almost all of them, both eyes, 6.6, 6.9, with at least N8 near. Intermediate is N6. 200 of these lenses, and I'll be very happy to say 125 of these lenses are Indian lenses. Okay, Indian lenses are also available in a very cheap category. I'll be coming to that. I don't have a slide I have a slide, I'll be talking about it at that point of time. Okay, now with this you can balance, but how to decide what lens for what person, that's a different talk. So technically speaking, these are also EDOF, but it's not classified under EDOF in the FDA category for insurance purposes only. That's all.
Sir, in continuation of what Dr. Elan was saying, your presentation, your wonderful presentation on monofocal and to some extent on EDOF. In our day-to-day practice, no matter how much we explain, talk in the scientific field that premium IOLs, you should look at the lifestyle. But at the end of the day, every patient, whether it's a computer-going, office-going person or a common man, at the end of the day, everybody wants to say, Dr. Sahab, nazdeek mein wo saaf nahi dikh raha hai. And we are coming out with so many lenses of premium monofocals and premium EDOF lenses. But at the end of the day, patient wants to see near. Just like Dr. Ellen said right now, what do you do in your practice to ensure that even though you are giving an EDOF lens, do you do some addition or something to this EDOF lenses that patient somewhere at least gets N8 or N6 partial?
Yeah, some of the patients require, most of the patients with EDOF require some amount of near correction.
How much addition do you do in your biometric calculation to make sure that the patient, even though compromises 6.6 may become 6.9 partial?
No, in biometric or after surgery. Biometry, you can just play with some amount of overcorrection in the other eye.
How much do you play with?
0.5 to 0.75 maximum.
That's what I want.
Okay, sir. Thanks a lot.
Thank you. Sorry, I have to go to some other hall.
Yeah, thank you for the. May I request Dr. Kumaran? He will be talking to us about multifocals and trifocals. Now, when we look at this talk, there are talks, you will realize that we have used all the technologies. Multifocals, trifocals, he'll be talking to us about the technology, advantages and disadvantages.
So good afternoon. At the outset, I'd like to thank one and all and Dr. Elankumaran and AIOC for this wonderful opportunity. So my talk is on technology, advances and disadvantages of bifocals. I would not be using the term multifocals because multifocals is an outdated terminology. So I'll be using bifocals, trifocals, and I take the liberty to add on another technology which is called the EDOF. See, whenever I tell my friend, hey, I implanted a trifocal today, the first question they ask me is the near vision good? And as the patient has glare and halos. Okay, these are only two things they ask. Okay, and the answer might be very simple, but how do you arrive at this? So my talk is going to be based on why is a particular lens causing less glare or less halos, and why is a particular lens giving you a better near vision than your other lenses? So these are the questions. Has anyone bothered to flip the pack of the IOL and look at all the factors which are mentioned there? What do we see? The price, the power, and the near vision. But there are multiple other factors which are also listed on the back of the IOL which we do not care about. For example, the refractive index, the chromatic aberration, the hygroscopicity. These are all very important for you to decide whether a particular lens is good or not. So on this basis, my talk is divided into two parts. The first part, I'm going to talk about the technology, the material, and the second part is all the questions which you had asked now. What do we have to do to give a better near vision in EDOF lenses? So I have no financial interest in any of these lenses. So this is how all the multifocals IOLs evolved. Do you know how many technology is there to correct presbyopia with IOL based? Any answers for that? There are 9 different technologies involved in a multifocal IOL or a trifocal. All we know is diffractive, refractive, diffractive, refractive, and EDOF. But there are also other technologies which are involved, which I'm going to talk about. So this is what I was telling. We only talk about the technology, but the other things we have to look into is the IOL materials, the IOL design, and the IOL property also. So this was the first time Dr. Hoffer is the first person who brought about multifocality. So any answers for this? Which IOL has the least chromatic aberration? You'll be amazed to find that your normal PMMA lens is the best lens available because the Abbe number is very high, the chromatic aberration is very less. It is indirectly proportional. But we never use these lenses. And this is the only lens, even if it is decentered, will not cause any glare and halos. It's much better than any of these lenses. But why do we run about hydrophilics and hydrophobics? The next thing which you have to look when you look into the IOLs is the refractive index. They're directly proportional. So more the refractive index, more is the chromatic aberration. So again, what is important? That is why the hydrophilic lenses are still in the market. They come with the hybrid material because the hydrophilic lenses are the one which has at least a refractive index and a better chromatic aberration. So this is what I was talking about. All these are listed behind your IOL box, the Abbe number, the refractive index. So next time when you want to put in a multifocal or a trifocal, please look into all these factors. Just don't believe what the representative says that this particular lens is good. Look into the Abbe number, look into the refractive index, look into the biocompatibility. These are all important for a clinician. The glass transition temperature, hydrophonicity is for manufacturing. Then the material which is involved, which I already told you about. So to understand multifocal and to implant multifocals or bifocals, you need to understand basic physics because if you don't know this, you will not understand multifocal and how it works in your patient. The first basic 8th standard physics, a refraction, you know what it is. Diffraction also, you know when a pinpoint of light is split into multiple colors. And then the latest technology is EDOF. Do you know where else EDOF is used? Do you know where else EDOF is used? It is used in your astronomical telescopes and your SLR cameras. So it is not new to our field. It has been there in the opticals for a very long time. So this is how a diffractive lens works. The center is for far, intermediate, and near, which all of you will be knowing. The major disadvantage, I told you, how does it cause glare and halos? We know a monofocal lens produces a single point focus, and all the light goes into the focal point, and there is a pinpoint source, and there's no glare and halos. When you come to a bifocal, we know there are 2 focal points. When one is at focus, the other is at defocus, and this produces a glare and halos. So what happens in the EDOF? The surface of the lens is modified differently to ensure that the light rays are not brought to focus, but they're made to collapse over a particular point, which falls within the Strum's conoid. If you go into your first year of ophthalmology, the EDOF depth falls within the Strum's conoid, and that's how the EDOF lenses work. And this does produce glare and halos, but is much less than the other thing. The other positive thing about the EDOF lenses is that it is able to correct your chromatic aberration. You could have seen some patients complaining of bluish tinge after you have operated on them. This you would find whenever the patient has an hyperopic error before the surgery, and when you give him a pinpoint 6/6, you will find that the patient complains the flames are more bluish. So this is what the chromatic aberrations. And as I told you earlier, the EDOF lenses, the elongation of the depth of focus falls within the Strum's conoid. So when you have a very demanding patient who asks you, sir, will I get 6/6? In those patients, always better to go for an EDOF because it is less forgiving on the errors which you make. So when you land up with a 0.75 or even a 1 diopter error, though these patients don't read 6/6 on your Snellens, they do not complain. So that's why I'm telling you, and EDOF lenses are less fogging to you when you have a demanding patient and when your biometry is off the error. So as I told you, there are 9 different kinds of technology involved. The first one is zonal refractive, which you know if you have been practicing multifocality in your 90s and 2000, you would have implanted a lot of these lenses. Then the aspheric refractive, the refractive technology lost its focus for a long time. Now it's come back again with the aspheric refractive, for example, the IHANS and Vivici, which my colleagues told you. Then the diffractive multifocal lens, as you know, Technis multifocal, which is still there in the market. Then came the EDOF diffractive. Then came the trifocal diffractive. So the technology, so the companies play with these basically three kinds of technology. And then comes the combined one. They combine both refractive and diffractive. They combine trifocal refractive and diffractive, and the EDOF bifocal diffractive, and now we have the zonal aspheric diffractive. So this is how they have been playing. So I given the names listed below the example is just for a reference purpose. I don't have any special interest in any of these lenses. So this is how you should look into how these lenses have come. This is a very important slide. That's what I would feel. So the bifocal, EDOF and trifocal, to understand that, please understand an EDOF lens will never give you a good N6 vision. It will only give you at the max N8 if you're bang on the target. If your distance vision is 6x, only then it will work. When you have a 0.5 or a 0.75 for distance, and EDOF lenses or any of the lenses will not work. Don't talk about multifocality. So first, refine your prediction error. Okay, refine your surgical A constant before you look into any of these factors. So as I told you, a bifocal works well for near and distance. A trifocal works is a compromise for all the three distances. So these are the common questions. Why do surgeons do not implant multifocal? The basic answer is dysphotopsia and glare and halos, and they're scared whether they would give a N6 to these patients when they ask you. I tell them there's no straightforward answer to anything. So these are the common questions we come across. Which presbyopia IOL has the most dysphotopsia? Please understand, whenever there is any lens which is more than a single focal point, you are bound to have glare and halos. There is no doubt about it. So every lens will produce glare and halos. The only thing is that what is the amount of glare and halos which they produce to you. So this is what you should remember. So this is a typical thing which you come across in any tier cities. You come across a 65-year-old chartered accountant seeking a spectacle independence. What would you choose? Different people do it differently. Whatever works best for you, please go ahead with that. There are so many combinations available. So talk with the patient, learn his lifestyle, look into what kind of personality he is, and then you decide it.
Yeah, you have time. You have time. Go ahead.
So all the questions which you asked have already been, studies have been done. So I'm going to take you to different studies which will answer different questions. So the first study compared three different type of trifocals which was first came into being way back in 1998. So in the first case, and all these trifocals did very well for near, intermediate, and distance. Then the second study, they compared a bifocal diffractive with a trifocal diffractive. That is, one eye had a trifocal, other eye had a diffractive technology. What did it give? The diffractive lens was good for near and distance. The trifocal gave a good intermediate distance. So you mix and match, the patients are happy. The next study, one eye trifocal, other eye EDOF diffractive. So what does it do? This particular patient, his intermediate vision will be very good because one eye he's got a EDOF. And he have a good vision for near and distance. The fourth study, they put a trifocal diffractive in both eyes, and they put a EDOF diffractive and a bifocal diffractive. This also works well. Okay, because one eye they have trifocal diffractive, other eye you have an EDOF and a bifocal. Again, it works well. The next study, they compared the light disturbances of three new IOL presbyopia, that is a trifocal diffractive both eyes, trifocal diffractive in both eyes, and an EDOF diffractive. They also did well. Then they compared the visual outcome and the different near addition. One eye they put a 4 diopter IOL, and the other eye they put a 3.25 ad. These also did well. Then they looked into the reading ability. The trifocal IOLs actually did a little bit better than the diffractive IOLs when compared with a 3.25 ad. But when they compared this with a 4 diopter ad diffractive, the trifocals didn't do well. The diffractive 4 diopter ad did much better than the trifocal IOLs. Then we talk about negative dysphotopsia. This everybody could have come across this negative dysphotopsia. This occurs more in younger patients, And with shorter axial length, it is less with your hydrophilic material than with your hydrophobic material. So again, though we talk about the PCO rates being more in the hydrophilic material, your negative dysphotopsia is very less. And what is the percentage of people who experience negative dysphotopsia? It's hardly 2 to 3%. But 1 patient is enough to take your chat time and kill your patients. The next one is the contrast sensitivity. The contrast sensitivity was least with the EDOF IOLs, and it is almost equivalent both to the trifocal and diffractive. Remember, the glare and halos are almost equivalent with the trifocal and the bifocals, and much less with the EDOF. EDOF also has glare and halos, but it's much, much less. Then do not put your patients on an autorefractometer when you are going to refract them. We always pray we don't have to refract them, but if you have to refract them, please do not put them on an autorefractometer, because the autorefractometer has not been designed for a multifocal setup. Please go for your retinoscopy. And among all the formulas, the Barrett Universal 2 works very well, but I would say you can also stick on with the IOL formula which you have been using. If it works well for you, you can definitely go ahead with whatever IOL formula which you are using. Then the influence of angle kappa. We talk about angle kappa or the chord length mu. Chord length mu is the new terminology. I'm not going to tell you what chord length mu is, because all the biometer tells you that. It's beyond the scope of this particular talk. Please remember, you can implant an multifocal or a trifocal IOL even if your chord length mu is high. The patient will definitely have 6.6. But when the chord length mu is more than 0.5, he would complain more of glare and halos. So whenever you go back to your biometry and see for these patients who have been complaining of more glare and halos, you definitely find that chord length mu has been high. It will not cause any problem with your visual acuity. Then the ocular aberrations, the angle alpha, would be a better predictor than your angle kappa. So finally, with all these studies, talk with your patient, understand him, make him understand the realistic expectations of what these lenses would give you. I have a negative counseling for all my patients. I tell them, you would definitely need a 0.75 or a 0.5 diopter. You might have, like how do we do a LASIK counseling. But for normal day-to-day life, you can be without glasses. So understand your patient, have a basic knowledge of these lenses, and then decide what your patient's needs. So choose what's best for your patients. Thank you.
Thank you, Dr. Kumaran. Only one question, just for the audience sake. Do you say chord mu 0.5, that's all? Because it differs with machine to machine.
Yeah, see, chord length, actually the older terminology is angle kappa, but what you have to do is a vertical and a horizontal measurement has to be taken, and both has to be added together, and if it is more than 0.5, that is called a chord length.
0.5 on which machine?
I use the lens star, so I follow the 0.5.
0.5. Because almost all these IOL calculating machines, that is your biometers, have a different reading from what you find on a pentacam or with a eye tracing. The reason for that is pentacam and eye tracing look at this angle on the cornea. However, while the IOL biometers look at it deep inside in the anterior chamber, just in front of the lens. So with the I'm not sure about, I have not used lens star, but with the IOL master, they say it's 0.33. Tomy doesn't record.
Yeah.
So
but what we need to understand is most of the IOL formulas have been defined and refined only through lens star.
Yes, most of it.
Except Holiday.
Holiday.
All the other formulas are European based.
Barrett.
Yeah, Barrett. Except Barrett.
The one which we use is
Yes.
not
So lens star has been the fundamental one to define all this.
So whichever machine you use, please look at that, read that book. These parameters, what we say here, might change. Look at that book and then decide it. It was an excellent talk. Thank you.
Thank you.
Thank you, Dr. Kumaran. Now I will invite Dr. Elankumaran Pasupathi. Now all of you know he is the director of Now Shakti Netralaya, passed out from All India Institute, practicing for the past 20 years as director, Now Shakti Netralaya, Bangalore. He will be talking on the right oil for the right patients, how to choose from the various technologies available.
Either. इसमें नहीं जाएगा ले लो बस Thank you, Dr. Umesh. And again, I would like to thank the audience. We were thinking there will be no audience for this last session. Thank you for staying back. Dr. Kumaran spoke about angle kappa, about about multifocal, trifocal IOLs, and there was a talk on advanced monofocal. Thank you, Dr. Kumaran, for covering it. Our speaker is getting delayed. He is still not come here. Now, we have these options. How do we decide what we are going to use? That's going to be the gist of my talk. He spoke about angle kappa. I'll be talking about something else which you can use to decide which lens to use for which particular patient. We have varied lenses, EDOF, trifocals and monofocals. Now mind you, that middle one, the monofocals also, we have got some patients at least who have had 6/6 and probably N8, may not be N6, N8. There are many patients happy with this. What is the reason for this? Have anyone thought of? It's not just astigmatism. Something else is also playing a factor, and that is what is used by IOL manufacturing companies to produce this advanced monofocal lenses. Now, what is the most important thing that you have to consider whenever you think about giving good vision to the patient? The first thing you look at is the toricity. Now, we have been traditionally taught that a toricity of more than 1, we do not use advanced lenses. But then, when it comes to multifocals, EDOF is slightly forgiving, but advanced monofocals or multifocals, trifocals, please consider this value as 0.5. But why did I put up this slide particularly? Right side, sorry, the pointer is not working on this thing. Right side, you can see the astigmatism is 0.72. So there is no question that you have to use a toric IOL, if at all, if you are using an advanced IOL. But look at the left side. The toricity is 0.13. But what happens when you feed it into a Barrett toric calculator? Look at what's happening. The Barrett toric calculator says, please use a T2 to get a proper value, T2, toric lens. So, point to take home from here, always get your readings, put it, feed it into the Barrett toric calculator. It's free, it's available free on APS-ERA's website. Feed it into it and then decide whether you want this patient to undergo a toric lens or not. This is something we have been following for the past 2 years and we have been getting very good results. Now, this was one of the reasons for all the unhappy patients. Also remember this, it's not just the IOL. The companies can talk about their IOLs, that their single IOL is the best. But then it's not just the IOL that decides this vision of this patient. Before you think about going into advanced IOLs, look at what the other things are like. Plan advanced IOL only in the normal eyes. If there's a problem elsewhere, be it the cornea, retina, or in between, even if there are floaters, a lot of floaters in the vitreous, please avoid an advanced IOL in these cases. Also, whatever instrument you have, hit this patient with that. See if everything is normal and then decide about your advanced IOL. Something which we all miss in our busy OPD, dry eyes. The most important things that creates problem in the post-operative period is the dry eyes. Look for it, assess the need of this patient. Need of the patient, I'll be coming back to it in the last slide. The patient might want a lot of things. He wants a 6/6, N6 vision, but assess the need. How do you do this? Need means what does it really require? Ask for his profession, ask for his hobbies. Now, there are questionnaires available on the website. The first one, what you see is a Speed 2 questionnaire. This was designed entirely for insurance purposes in US, where it talks about advanced IOL. But look at the second questionnaire that goes into what is the daily activities of this patient, what is he using. Have this questionnaire, or at least you can talk to the patient a couple of minutes. Your counselor will not be able to talk about this, and then decide what to use. Now, this is what I'm going to talk. Forget about everything else. Look at this particular chart. It's difficult to get, it's usually found in some machines, topographers. Pentacam is what I have. And what is that small circle there? That's a spherical aberration. Before I began this talk, I said IOL companies utilize a particular parameter. They have been using the spherical aberration to bring in some amount of extended depth of focus in monofocal lens. So how do you use this spherical aberration? Before I go to that, if any of these parameters are above this on a pentacam, coma, total aberration, spherical aberration, above these values, these are normal values. If it is above these values, please do not think about again advanced monofocal, advanced IOLs. Go for simple monofocal IOL. Now, asphericity is what I was talking about all this time. We know that the cornea is aspheric, but then it follows a parabola, and what is 0.53 or asphericity is considered to have no spherical aberration, zero spherical aberration. But do we all have that zero spherical aberration? We'll come to that. But before that, a person who doesn't have a machine, what does he do? Now, I have a pentacam, and this is where I look at. That's the value I use for the pentacam, and this is where I look at. Look at that area. Spherical aberration in the 6 millimeter zone. Now, in this case, happens to be 0.522. If we take this value as 0.6, then he comes within that range. But that's not our goal. We want to use this spherical aberration to proceed and give freedom from glasses to all the patient. The best machine to calculate this, of course, is an eye tracy. I do not have it. If you do not have a pentacam, please talk to a friend. You can send him there, get it done, and come back. And then go ahead with it. Now, in a cataract patient, this is copied from Dr. Uday Devgan. If it is a, just simply speaking, if it is a hyperopic LASIK, which has been done previously, then go for a non-spherical, the traditional IOLs. Traditional IOLs, which was positive asphericity, go for that. Now, if there is a prior myopic LASIK, choose a negative asphericity. No prior surgery, then the problem comes. If there's a likelihood of IOL decentration, such as pseudoexfoliation, Marfan's, or one of those disorders, then think about aspheric IOL with the thing. IOL not likely to decenter. This is the place where we have to decide. Now, there are two options here. You have already seen the profession of the patient. You have seen his activities. So, if the patient needs crisp vision, then you go with the slight negative asphericity. How much should it be? Minus 0.1. If the same patient needs depth, meaning he can adjust a little bit of reduction in the contrast, little bit of reduction in the quality, but he needs the depth with that lens, then you go for minus 0.25 to minus 0.35. Remember these two values. 0.1 gives crisper vision. This is the total asphericity, not just the cornea. I'm talking about the total asphericity. Now, 0.1 gives crisper vision. 0.25 to 0.35 gives the depth of vision for around 1 to 1.25 diopters. Look at these two values, then we will see how to do it. Like, a normal cornea is not zero. It is around 0.25 to 0.35. So, nature has already given this to us. This is one of the reasons why a child's cornea can give a certain amount of depth of vision, also providing clarity in vision. So, remember this. And in our patient, it was minus 0.52. We'll take that an example and calculate later. Now, when you consider this, in that normal range, you can go for any premium lens confidently. Target, if you're going for a trifocal lens, already this multifocality is provided by the trifocal lens. If you're using EDOF, again, EDOF is providing that multifocality. So, what should our target be? Cornea, let us say, is 0.5. We have to use a lens with a spherical aberration of 0.27. There is a lens. Highest we have is 0.27. I'll be coming to that. 0.27. So, what are we doing? 0.5, 0.27. We have brought it down to almost 0.13 to 0.2, closer to 0.1. So, we are targeting crispness, but multifocality is provided by other technology. Okay, any doubts on this? You can ask me, because it's slightly confusing. I took almost 3-4 days to learn this. So, if you are providing trifocal lenses, target that 0.1 final. How do you do this? Just like what Kumaran said, take the lens, or ask the person what the asphericity of that particular lens is, match it with the cornea and produce this 0.1. By chance, patient is not affordable. He wants to go with a monofocal IOL or an advanced monofocal IOL. I'll take a little bit of time. There are some speakers not there, so I can afford to. Patient cannot afford. He wants to use a monofocal lens or an advanced monofocal lens. What should the target be? The target finally should be 0.25 to 0.3. So our patient have 0.52. When you put in 0.17, there's a lens available with that also. I'll be coming to that later. I'm not going to name any lenses. I'm only going to give you values. Please find out from your distributor. Indian lenses are available at 0.19. So you can use any of these two lenses and bring that value within 0.25 to 0.35. This is what we have to do if we are using an advanced monofocal IOL or a monofocal IOL or even a trifocal IOL to produce good vision. So, if the spherical aberration is beyond that range, try to avoid this multifocal trifocals. EDOF can be used, however, talk to the patient and use this value to your advantage, and you can use an advanced monofocal IOL. This slide sums up everything. The first one, where these spherical aberrations can be classified as toxic and non-toxic. Toxic, where it's going to create trouble to the patient. Now in those cases, avoid premium at any cost. The top one and the bottom one are the toxic ones. You can look at it. The in-between ones, definitely in the normal range you can use anything close to it. You can play around with the spherical aberration and bring it to this level. This is one thing what I have started doing in the last 2 years, and I've been getting good results. Now we spoke about the cornea. 0.25 to 0.35, say that is the normal limit. But then lenses are available. The traditional lenses what we were using were plus 0.15. Now you understood why that is required for a hyperopic LASIK. In a hyperopic LASIK, we are inducing negative asphericity, so that's why that is required. The maximum asphericity that is available is 0.27. I'll just name the lens here, that is Technis, in case you need that. Minus 0.2. In this, actually there is a range from 0.17 to 0.2. Indian lenses, the IOCare lenses are available here. Alcon lenses are available here. 0.17 is Alcon, 0.19 I think is IOCare. You can just confirm with the value, write it down, so you can use it in this range. So, person with 0.5, if you want multifocality, use this 0.2. If you want good focus, use the 0.27. And there are zero asphericity lenses. Rayner, what Dr. Subhash Prasad sir was talking about, is a zero asphericity lens. So ask the distributor, read the box. Zeiss also is a Zeiss, Zaracom, lot of lenses are zero aspheric lenses. So you can talk to them and use it to your benefit, and you can give a reasonable amount of multifocality to all the patients. Sorry, slides are going back. Now, finally, I would like to talk about, I've already spoken about this. It's not just the occupation of the patient. We are beyond a stage where only work is a criteria. Many of them have such exceptional hobbies which we forget to ask. So always ask about it, and then you decide, then you counsel the patient. Dr. Kumaran was talking about a particular patient who comes and says he needs 6.6, N6. There are many patients who come because they know these two values. That patient never put in an advanced IOL because he is going to be the biggest troublemaker. Try to talk to him and say, whatever lens I am going to insert, there is going to be a residual power. Defocus curve was discussed before also. Just look at this defocus curve. Anything what you use, there is a residual power. Let's remember that. Anything what you use, you're going to have dysphotopsia. Remember this. How do we reduce it is what is most important. Again, this is copied from Dr. Uday Degwan's website. You can go back and see this. Now, to get a refractive success, assess that wants and needs. Patient may have 1,000 wants, see what he needs. Rule out all our pathologies in the eye. Look out for dominant eye. This is something which I forgot to tell. I think all of us know how to look out for a dominant eye. Simple test, you can just do this and ask him which eye he is focusing. Usually that is the dominant eye. match the Q value, rule out the aberrations, communicate, document that communication, and then go ahead. Money is very important, but that's probably the last one to consider. Also, spend a lot of chair time with this patient. Thank you for the opportunity provided. Any questions I would like to take?
Yeah, thank you, Ellen. I think very wonderfully he's clearly described about all those things, especially the asphericity. And sure, those who have Pentacam, you have to buy the additional stuff. Those who have Pentacam, they have to buy the additional software for that, but those who don't have, you can try to look for it. Any questions? I think we'll take after the last
After the clinic.
After the last talk.
Next speaker, in case we have did all these things, still we get up an error, how do we correct it? Dr. Umesh will be talking about it. He is the head of Shankara group of institutions, Bangalore.
Thank you, Dr. Ellen. Hopefully we'll be on time. This is the last talk for the whole conference. Post-operative, in spite of all the previous speakers who have spoken and the advances, technologies, technical advantages, biometers, I'm sure all of us here have faced this, irrespective of any of this. We have faced post-operative refractive surprises, and now the question is how we are going to go ahead and manage it. Now, what is a surprise? I think reasonably we are okay with up to 0.5, and anything more than 1 plus minus 1 diopter, we should consider it as a refractive surprise. In case you have 0.5, 0.75, you can always adjust in the other eye so that you get a good binocular vision. But if it is more than 1, you know it is a surprise. And as I said, the older studies gave around 70%, and the newer studies are giving 93% only. So there is around 6 to 7% surprises always happening with us. It could be spherical, it could be astigmatism. So we have to be prepared for it. And what are the causes? In our thing is, with the advent of the newer technologies, the inaccurate measurements have slightly come down. So as Dr. Ellen said, dry eye disease, sometimes you are not in the bag, one in sulcus, that is misalignment, capsular blockage, wrong lens insertion, especially in centers like us where you do high volumes, that is one thing, and it's becoming more often than not becoming common. And one thing is post cataract hyperopic or not taking a proper history. I know that people have come, they don't give history, we go ahead and we do, and post history he says I had a surgery, LASIK surgery 20 years back, and that is when you know. So that history you have to be very careful. The post-operatively, once you know that there is a refractive surprise, what do you want to assess? Make sure you do a manifest refraction, post-operative review the measurements. Now we have pseudophakic measurements also. Sometimes, very rarely, the problem could be with the IOL power. He would say 25, it could be 23, 24. So make sure that you get it right. Of course, slit lamp examination and dilated fundus exam with respect to IOL, make sure there is no tilt or not decentration, rotation. Mostly what we are seeing is it could be one in bag, one in sulcus. So that will induce some astigmatism. And capsular blockage, you make a small capsule, there is a nice swelling of the capsule, the lens is tilted forward, you end up in -2. You just go ahead and do a small YAG laser, everything becomes normal. So that is one thing that you have to see. Repeat biometry, do a topography to rule out if there is abnormal cornea, and of course patient counseling. Management, spectacles up to 2 diopters, hook or crook, counsel the patient, tell him that he has very good near vision, especially if he is myopic. I would counsel him, spend more chair time and tell him that he has got very good, and most of them accept it up to 2 diopters. If for near vision, if he can do, and if you tell him, the problem is only in the hyperopic patients. Even in hyperopic, if you can explain up to some extent, they will get, if you spend more chair time, you will be okay. Contact lens, of course, out of question. IOL adjustments, rotation, repositioning, yes, in some cases of toric lenses may be necessary. That's a different topic, we'll be not talking. Limbal relaxing is more or less out, we don't do, though we tried a lot, including the femtos and all, but mostly it is all coming back. It is only for academic purpose. Piggyback, some instances we do see, I've just explained that. Corneal refractive surgery, yes, we are doing, and light eye is only for academic purposes. So keratorefractive indication surgery, that is LASIK, is error of less than 2 diopters. Yes, I do up to 4-5 diopters. Okay, make sure there is no corneal pathology, no glare, halos, no contrast, and no sensitivity complaints. That's very important, and more important in these patients, rule out if there is any dry eye. IOL exchange more than 3-4, I do, though they recommend up more than 2, I do for 4. And in the multifocal lenses, if they are not adapted for any reasons, just don't go and try more than 6 months, they're complaining, 3 months they're complaining, better exchange. Rotation, obviously, it is the toric IOLs. 30 degrees of rotation you have to do, so that it loses everything. Piggyback IOL I have used if there is a hyperopic surprise, or if there is a pre-existing PCR and you can't do but you still want to do, you can go ahead and do a piggyback IOL. IOL rotation ideally between 2 and 4 weeks. Online calculators are available. Use the astigmaticfix.com. And in case of PCR, sometimes we can do a reverse optic capture, but otherwise just leave the cylinder if there is a PCR and manage with the patients. IOL exchange mainly, I have done mainly for wrong IOL insertions. Sometimes it happens, 4 diopters, 5 diopters, and multifocal IOLs. We advise best before capsulo-lenticular adhesions develop, and of course if you have some complications. So technique for IOL exchange, what you need to do, you need to have 2 good instruments. One is a micro forceps to hold from the side road. Any VR surgeon will give. Initially we were having a lot of trouble getting the right but nowadays the Indian manufacturers are doing a good job, but you have to get the right scissors, and the scissors is the IOL cutting scissors. They are very with a good hinge, and they are the saw type scissors. They are specifically IOL. You can't do with the Vanas, you cannot do, you need to have that. They are, so what you have, different methodologies are there. You either cut it into 2 halves. You all know IOL is 6 mm, you cut it into 2 of 3 mm, slightly extend 3.2, and each you can get it to 1. So you either make a full through and through cut, or you make a 3/4 cut and get it out rotated. So this is a through and through cut, you get one out and you hold the other one and comes out. So understand, 6 mm, cut it into 2 half, 3 mm, 3 mm, 3.2 opening, you get it out. There are some technologies where you make a pie and you can even get it out from 2.2. I think that is too cumbersome, and you need the best of instruments for that, and without that I wouldn't suggest that, but if you have, it is there, you can get it out even with a 2.2 millimeters. The other is make a half cut, and this is a multifocal lens. You just make a half cut and then get one part out and rotate it. You just rotate it out and it will come out. So 3/4 cut done. The forceps is very important, holding. If it slips, then there is a damage. So we only cut up to here and then get this one portion out and just do a rotation technique and it comes out. And some of us have even tried with the hydrophilic lens without cut. You just do a pulley technique, it just comes out. But be careful, don't injure the this one. This is the rotation, so it comes out in toto. So that is one technique that we normally do. Piggyback IOL is less complex, more accurate and reversible because there is a clear cut to this one. I have tried. Usually they say don't use the same material, you use a different material because there won't be interface this one. So I have in one cases which was a very high hyperope, I think he was 34-35, lenses were not available, 36 or something. I put a hyperope, so I used a implantable IPCL in that, and they're doing well. But the other one that are advisable are the Sulcofex lenses, and the other patient is doing well. And these are only select indications. If the patient is really motivated to get the correction, you can go ahead and try these things. and we have some options available with us. IOL exchange versus piggyback lens, mainly in the piggyback lens, either it is the hyperopic, not in the very long axial lens, in the zonulopathy if you have, and if there is a posture capsule compromise, you can go with the piggyback lenses. Corneal refractive surgeries, I have done quite a few where IOL exchange is difficult, there is a PCR or AG already done. We are normally perform 3 to 6 months after to ensure that the refractive stability is there and also mitigate risks of wound dehiscence, especially if you are doing a cut. And in multifocals, dioptics was used before, but somehow I am not for it because multifocal itself is inducing aberrations and you do a dioptics that will induce. So nowadays most of us don't talk about it. Maybe very finicky patients, you want to try only one eye with a 0.5 or -1 only sphere, probably you can try dioptics. The limitations obviously are very high refractive error and corneal thickness. This is a case of slightly undercorrect, maybe if you're correcting -4, in this case it was -3, I corrected 2.75, patient very happy, you could go ahead and do. We also do LASIK in this limbal relaxation, I said we're not doing much, though some of them have tried. Even light adjustable IOLs are purely from academic purposes. I just mentioned it for that. But otherwise, I think these are the different things. Thank you, Dr. Ellen, and thank you everybody for staying back till 1:30. I'm sure it was informative and helped you a lot. Thank you very much. Any questions? Probably Ellen can take.
Any questions from the audience? Once again, thanks a lot. First to the, yeah, please.
Actually, what you started with first monofocus and doing just monofocus for now and trying to convert. The concern for me is you have said that light waveform, some amount of distance vision is taken away to contribute then to intermediate and vision waveform. How much of an issue for this special according to your experience?
More than in advanced monofocals, unlike the ringed trifocal or ringed EDOF, not much of a light is taken. But the problem is that these photopias do exist. This is the reason they have not gone beyond 1.25 diopter correction. Otherwise, just by increasing the Q value, you can go to any level. But the problem again is, this is in the center. So you have to look at the pupil status. If it is a small pupil, this advanced monofocal is not going to act. In fact, it may create trouble because the central part is slightly myopic.
No, it increases depth. Already there is increased depth of focus.
If we further
So
increase.
in such cases, you may have to slightly undercorrect and use that.
Okay.
See, understand one thing for EDOFs, the advanced monofocals, since it is 1.25, that is where occupation, Ellen was telling about the occupation. So you tell them there are patients, 60 plus patients who don't want to do computer work. The computer work, when I say look, typing, font size, N11, N13, N14, they, for 5-10 minutes they can manage, after that they'll complain of strain. So you cannot promise them with advanced monofocals good intermediate vision. Their VVT comes into play. They have very good, but there are 60 plus now doing a lot of YouTube at intermediate vision. They want to see smartphones and all. They are the best candidates for this one, but you can't promise them that long time of computer work, the regular computer work with N11 font size, or obviously reading. So these small occupational things, if you can understand and counsel, I think they do, advanced monofocals do very well for your patients.
For distance vision, like 6 is there, but the reduction in the brightness, there is some reduction in brightness because of that. Does that make an issue, or?
It is not a major issue with advanced monofocal IOL for the reasons told. Second thing, I just want to add what Dr. Umesh has told. Among all these advanced monofocals available, definitely the Rayner EMV is doing better. The reason for that, what they say, like what you was telling, continuously when you look at intermediate distance, the eye develops strain. But what they have did in that lens is, towards the periphery, they have induced a slight amount of hyperopia. If you look at that defocus curve, and they claim this is what is helping the patient, it doesn't tire him. But again, it's only a matter of minutes. If he's working for long.
So, now if you have young patients, now most 50 plus patients, they are all computer users. Don't promise them that for continuous. It is just, say you're going in a flight, or you want to see some YouTube, you're going to a flight and you want to see the numbers there, that will help you. But you want to see continuously, you have to go for.
Any other questions? Okay, thanks a lot.
Thanks
Thanks
you.
a lot, and to my fellow speakers also. Thank you.
Thank you, Ellen. Thank you, everybody.